inaugural times and after that it was very frustrating because no pregnancies. We had so much of limitations. And in today's time you have everything. Today we say, okay, if you have a desire to have a baby, we can help you to give you your baby. You will see your own image in the baby. So you just need a desire to have. Yeah. No, let me tell you one thing, very interesting. My role comes after the wiki donor fails. You know? So wiki donors of all the regions have failed repeatedly, then the patient comes to us. Because we are just, after that. And let me tell you, wiki donor had so many failures, but IVF scheme nobody has failures. Now we are doing guaranteed program, and I can tell you day one, who is the patient who will get pregnant, who is the patient who will never get pregnant. And if you make them set their mind, psychologically, see the financial ability, see the problem, see the depth of the problem, what you can do it, what you cannot take the problem. And if accordingly you start, I think anybody can get it. No doubt we know every month you cannot get it. But still we know what are the probabilities of it. No doubt, probabilities are not that excellent. But still, if you feel, you have a gut feeling that this patient can get it, give them. Otherwise, we should be very blunt and clear. So today I am talking about on a very different topic, PCOS, which we see day-to-day life. Now we normally say PCO and PCOS sometimes, but we have to categorically differentiate between the two. Now, what is PCO and what is PCOS? PCO is a general condition. It cannot be, we cannot say that it is a disease. It is just a variant of normal OP. And normally what we see PCOS is hypertension. She had a normal hormonal milieu, normal periods, but she gets married, then she is under so much of stress because she has left her family and come to another family, totally new people. Then there is somebody to take care of her, weight gain. So it's a roller coaster for the lady. So that lady who had normal hormonal milieu, and she tends to get into a PCO. So these are all hormonal imbalances which we see in day-to-day life. Now we know that PCOS is a metabolic condition, and there is a very different criteria for diagnosis. If at least you have two things out of these three should be present. One is the physical and biochemical signs of hyperandrogenism, oligomenorrhea or anovulation, and polycystic ovaries by ultrasound. See, nowadays ultrasound is a magnificent tool. The moment you put the probe in the vagina, you know everything. It's a Pandora box. I feel the moment you see a patient, you should put the probe in. No doubt, patient may hesitate, but you should be very confident because every day you will learn something or the other. Because the menstrual cycles are, regularized, you know what you expect. And if you are, you have in mind that what you are going to see inside, that is always better. Now, what is the polycystic ovarian syndrome? The commonest cause of anovulation we have seen is PCOS, and 70% patients who are, anovulatory, they are PCOS. Then it is characterized by anovulation, polycystic ovaries, and hyperandrogenism. What I do in my practice is, the moment patient enters into my room, my eyes are on her. I can tell you the weight of the patient, the height of the patient, the masculine nature of the patient, of the feminine characteristics, hair distribution, So you know the androgenic features in the female. So when she is inside, you know that, okay, this is her problem. Now, no doubt, you have to go through whatever she has done, her hormonal profiles and all, and the moment you put the probe, you know everything about it. So now diagnosing has become so easy. And if you really look into the previous stimulations of that patient by other doctor colleagues, then you become very sure that what is the fate of this patient. And then accordingly, if you start from the beginning, like you know about it, that what you can achieve or what you cannot achieve. And if PCO patient, let me tell you, half of the PCO patients, they have abnormality in the husband sperms. If husbands are normal, they will get pregnant. Maybe they will not get pregnant, the way normal couple will get, but maybe once in 2 months, once in a year. But they have good chance. So as Dr. Sharma was also pointing out, I feel the biggest treatment for infertility is regular intercourse. Nowadays I tell my patients a phrase, if you don't have intercourse, then don't eat that day. It is that important. Because what happens is, because we have trained them like, you should have relations on ovulation day and all that, and maybe ovulation kit. So they do the ovulation kit and then they go to sleep. So you have to advise them, then what is the need? See, oligospermia, female vaginal cavity is a sperm bank. You have intercourse today, outside the sperm will die in 12 to 18 hours. Inside they will live for 1 week. So if you cannot do anything more than that, you just encourage them for frequent intercourse so that the number increases. There are, sperms in the vagina all the time available to shoot the egg. So to welcome the egg. So people, if you see general population, number of people, like I was just going through literature, that 5% of the people in general population have azoospermia, and still they have children. So no doubt, still they have some severe oligospermia, but there was sperms, because you just treat single sperm. So male infertility is really treatable. If you find there is a male infertility problem, female is ovulating fine, then better encourage them for regular relationship. Rule out the cause in the husband. And most of the time you will see that husbands have problems like long time confinement to bed, road traffic accidents, hepatitis, or some other chronic problem, or high-grade fever, or patient is on antihypertensives, or patient has lost interest, and they don't have intercourse at all. So these are the things which, you can treat. So you have to know beforehand that what is the problem of the couple, and then only I feel you should proceed further. Now see, this is the classical polycystic ovarian size, necklace sign, and nobody should miss that. And it's a collection, it's a mortuary, you can say that. Undeveloped eggs, they have not ruptured and they have got together. So we should try to avoid this. Now a little bit more on the PCOS and PCO. PCOS is not that common as PCO. PCOS is 5 to 10% patients, and these are the couples, where you have to really identify. Look into their family history, look into that she is obese from childhood or not. Were you a chubby child? So this is to be noted. And then, is there a history of gestational diabetes? Your mother is diabetic or not? Cardiovascular disease, endometrial cancers. These are the patients, who in future will develop into diabetes, they will get obese, So we have to be very careful and we have to educate them. Nowadays, we get a lot of patients who are not married. They come with the mothers and mothers are worried that she is not having periods or she is putting her weight. So those times it is very, very important, to guide them and diagnose it and then make a guideline for them. There are two patients who came to me when she was 14 and now she has two babies from us, two of them. So their mothers feel so excited that okay, we came to you at the right time. That time I was confused why they have come to us. But now I feel that it was the right advice for them. So my advice to them was, I corrected their hormonal cycles, menstrual cycle, and I told them, because she will never get pregnant without an assistance. So look for a husband who will be mentally fine, little low socio-economic than yours, little accommodative, and family should be like that, who is ready to accept the treatment. And this is what they did. Once they got married, they came to me and did the treatment. So we have to go into in-depth of the patient's problem, and once you know that in our scenario, if a lady has a baby, then there is no end to it. Then PCO patients, I feel one should, my talk today is on PCO patients. PCO patients, you can even hydrogenic them. Childhood and this fast food trend nowadays, eating so much of carbohydrate and so much of fat. So we are making the patients PCOS.
But that is not there in the rural India. It's only there in metros.
Because we are all eating, whatnot. And I feel the biggest blame is on the roti. We feel कि हम रोटी के लिए खाते हैं, but roti is the biggest hazard. Atta. So this is what Britishers gave us. So we have to really leave it to become diabetic free. That is the reason to have diabetes, pot bellies like me, and eating sugar. So those things which are not meant for human eating, human consumption, we should take care of that. Now you all know that PCO patients, you will be able to diagnose only on sonography. They do have regular ovulation, they have no symptoms, and conception may not be difficult. But otherwise, PCOS, they have acne, hirsutism, weight gain, anovulation, and they may struggle with infertility, and they may have miscarriages more than the normal count. Now, what is the genetic basis of PCOS? Initial studies suggest that it was an X-linked dominant transmission, but recent studies suggest it is an autosomal dominant inheritance. See, there is a big shift. Now, risk of developing PCOS is 40% if sister is affected, and 10% if mother is affected. So we have to see the lineage. We have to ask the patient that you have a sister or she has babies or not. Normally you will find the problem is there. And so it is genetically linked also. Now, who are the females who will become PCOS? Now, if you have intrauterine, see, during the fetal life, if you have androgenic drugs and progesterone given to the mother, these are the fetuses who are likely to develop PCOS. This is a recent study which shows that. Now, pathophysiology, all of you know. I'll just try to be very fast. Insulin resistance and compensatory hyperinsulinemia, hyperandrogenism, inositol deficiency. This vicious circle, this is all interrelated, so we land up into the soup. Now, symptoms are menstrual abnormalities, hyperandrogenism, obesity, diabetes mellitus, metabolic syndrome. Now, what are the symptoms? Hyperandrogenism is hirsutism, Like I ask my patient that how often you go for the upper lip and how often your husband goes for the haircut. Maybe you go more than him. So then you get the answer from them that what sort of hirsutism they have. Then acne, male pattern balding, all that. Obesity is present in 50% of the patients with PCOS, but PCO you can find lean and thin PCO and obese PCO. They are different, they respond differently. Then diabetes mellitus, patients who got pregnant, 10% will have type 2 diabetes, hyperinsulinemia, cancinosis and obstructive sleep disorder. So they have put up so much of weight that is the problem. And for them it is very difficult to reduce the weight. इनका ठंडे पानी से भी वजन बढ़ जाएगा. So you have to really tell them that you are into that soup. So you have to differentiate between PCOS and PCO. And
ठंडे पानी की बात बंद कर दो, बस पानी से ही
absolutely right. Now obesity and PCOS. Obesity is associated in 35 to 60% of cases, usually android type, raised waist hip ratio, increased waist circumference, and also associated with insulin resistance and hyperinsulinemia. Now, what are the different clinical situations? Is newly married, they're not wanting for conception, but they want to have regular periods. Married, wanting conception. Married, has one child and now wants spacing and have a second child, or they come for second issue. Or, as I mentioned, unmarried girls brought by the mothers and they are worried about their menstrual irregularities and weight gain, so they come. Now, obese people who have high BMI, hirsutism, oligomenorrhea, then how to manage these patients? It's most important. In today's time, no doubt we are handling IVF only, but we are doing counseling to the society that so that you may not become PCOS. Maybe you are normal, your hormones are normal, but it may go abnormal. See, man is made, a female is made for 50 kg and the hormones are there inside the body like that. But if you gain weight, you become 80 kg, then those hormones are not sufficient for you. So the ovulation will not happen. So we have to guide them accordingly and try to tell them that, okay, if you are able to correct your weight, if you are able to, eat what is right for you, then you may not need IVF treatment at all. So, but that has to be done from the beginning. After gaining weight, losing is very difficult. So still, diet restriction and exercise is the sheet anchor. What I tell my patient is, I have, skipping ropes and I use 100 in a month. I give it to all my patients and tell them you have to eat half what your husband eats and no white things. Avoid atta, maida, sab kuch. Eat jwar, bajra, rai and all that. Decently roti kha lo. So have your diet started, diet regulated. Eat more of vegetables. No sugar at all and no milk at all. So you don't put her weight, then you are on the losing side. Then put an exercise regime. I tell them, let her take the best sports shoes in the market and use it. And make a chart of your sexual relationship. How many times in a week you had sexual relations, and the day you never had it, so I'll see to it. And they bring their chart. And I have seen patients, they become psychologically very good, very positive. I just tell them that doctor is not a jadugar, so we can simply advise, you have to apply on you. So if you educate them that way, firstly, the most ignorant thing is they don't sleep. And once they are awake, they are watching TV, they are eating and nothing doing. So this is one of the reasons to gain weight. And over a period of time, they feel, doctors have trained them that ovulation time you should have intercourse, and they lose interest, and that's it. They don't have relation once in a month. One patient, interestingly, I asked her that how often you have intercourse. The patient said, doctor, we're married for 30 years, and I always lock my door when he's outside, because he comes late and he enjoys with his friends, and when he is home, I am asleep. So I don't want, he has never come in, so no sexual relationship at all. So we have instances like that. So we have to really encourage them to have sexual intercourse. Now low glycemic index diet certainly helps, and carbohydrate and fat restricted diet. I have seen that keto diet is the best. If they can follow it, you take low carbohydrate, high protein and high fat diet. You will lose weight. So that is what works. Now even we have seen 7% of weight reduction. If a lady is 80 and she loses only 5 kg, she may get back her ovulation.
She's
So
just
weight,
pregnant.
yeah.
Do IVF failure earlier.
So weight reduction is that important. Now moderate physical activity, 30 to 60 minutes per day, should be goal of all the patients with adolescent PCOS. Now what is the mechanism of action? We feel okay, you have advised, but patient wants to know how does it work. See, it lowers the circulating free androgen and insulin levels and increases sex hormone binding globulins, thereby decreases the level of free testosterone. Now, we have treatment options for them depending on the problem, depending on the symptoms, like if it is more hirsutism and acne, and what stage they have come to you. Are they in the birth planning stage? Then you have to use these hormones only to down-regulate. So we have preparations available. We have to really design our protocol for them, that where do they fit in, and we should not take up them immediately for IVF. I feel preparation for IVF in a PCOS patient is very important. To how to diet and down regulate, how to control the ovaries, how to settle the ovaries, and then only we start the stimulation. About 5 years back we started in vitro maturation, because we know that these patients will be hyperstimulated, may land up into problem, and especially lean and thin PCOS, because there is not enough space in the tummy, and they are, they like explode. So for them, IVF was the treatment, but gradually it has been off. So we had only one pregnancy, we did in 6-7 patients. So it was not very good. The international success rates for IVF was very low. So now it is almost over. So today we have come to freeze all. The moment you see the estrogen levels at the time of pickup is more than 3000, and patient will land up into mild or moderate hyperstimulation. So it is better you fertilize the eggs, freeze the embryos, freeze all of them, and next month, because her uterus is fine, she will have excellent chances of implantation. So this is what we are doing. So now hyperstimulation is almost going out. Then you have protocols available, antagonist protocols. Then you are triggering by GnRH. So you are controlling your stimulation. Now we know that who are the patients who will get hyperstimulation from the beginning. Seeing the AMH level as a predictor. If it is very, very high, if you have necklace sign, if you have very, very small ungrown follicles inside the ovary, maybe you have a multicystic ovary, So these are the patients where you have to take utmost care. And there was a question in the audience that unruptured follicle. See, if there is a problem in the stimulation protocol, if you are not very vigilant on the hormone profile of the patient, and what stimulation you are giving to the patient and what dosage you are giving to the patient. See, you have to target your ovulation time, you have to make your follicle ready by day 10. If you have increased your dosage faster, follicles are ready in day 8, it will not rupture. And if you have not given HCG at the right time, it will not rupture. So there is nothing called LUF now. You have to know the reason why the follicle has not ruptured. So nothing like, ovarian cyst and all, which were nothing but the unruptured follicle. So we have to see where we are lagging. As Dr. Sharma also mentioned, that if there is a history of ectopic pregnancy, and you have done laparotomy, you have had the couple, she's all right, but once you have closed the tummy, there will be a lot of adhesions. If there is endometriosis, there is menstrual blood splitting around, spilling around, and then adhesions. So if there is any history of tuberculosis, so what will happen? Adhesions. So if these adhesions are forming, then you have to know what you are doing. If you feel that, okay, there is a fluid in the tube, so what to do then? So if you are very careful about these, then if you see that there was a question that the response is not that good. See, if you know that, okay, these are the follicles and these are the kind of drugs you are giving, this much you expect, like on day 2 you start and day 8 you should have 14 millimeter and all that. It's not coming. So either there is some infection which is not letting the follicle grow, or the drug is not good. So we have to have our mind and eyes open all the time. Then we have to match it with the dating of the endometrium all the time. Our eyes should be open, seeing the follicle, seeing the endometrium. And then I believe today's time you don't need any hormonal access, because patient is a patient. So you have to cut down your cost, not unnecessarily, but evaluating the couple, then you should decide your, that what all shall I do, what all shall I not do. Now oral contraceptive pills is a must, when you start with the PCO patients, they start doubting you. The doctor, we have come for conception and you are giving us contraceptive pills. Are you mad? So you have to make their mind set that why you are doing this, and you have to be very selective in the selection. Now advantages are you are able to regulate the cycle, there is no weight gain, and then control androgenic symptoms. Now ciprofloxacin acetate is the best OCP for PCOS, and it can control hirsutism, and it competitively inhibits the binding of testosterone and also dihydrotestosterone to the androgen receptor, as Dr. Sharma mentioned. So dose is very simple and it has to be repeated for about 6 months time, and things are getting better. Now lean and thin PCOs. Lean PCO may also have insulin resistance, and therefore if they do not respond to oral contraceptive pills, insulin sensitizing drugs has to be added. There was an era when metformin was given to anybody and everybody, and then I remember we used to just check the sugar levels, random sugar levels. We were always worried that patient may go into hypoglycemia, but metformin is a wonderful drug. Even if you are giving unjudiciously, things work, but it should not be given to everybody. And how does it work? You all know. Now there are side effects of metformin, GI symptoms and all. So, but still they are tolerable, and if somebody is unable to tolerate, then we have to look for other remedies. See, now lifestyle modification, most important. Then no doubt now the first line of treatment was clomiphene citrate, but today it is letrozole. And letrozole is a wonderful drug for monofollicular development, and you don't have anti-estrogenic effect on the endometrium, and you can avoid multiple pregnancies. But the biggest problem now we are facing is that we are using for a long time. That should be avoided. Now, infertility in PCOS, if somebody is failure to ovulate and there is hypersecretion of LH, premature endogenous LH surge, hyperinsulinemia, insulin resistance, hyperprolactinemia. Now, let me tell you, hyperprolactinemia is very difficult to diagnose, but very easy to correct. So if you have time, what I do is, I tell my staff nurse to see breast discharge. And the patient, I tell them, okay, to see the breast discharge, she will say, yes, it is there. So you can assess the thought process of the patient. So if you are doing precautionary treatment for hyperprolactinemia, see, capgulin is a wonderful drug. If you give just once in a week for 4 weeks, because you have to switch it off when you are starting stimulation, so you can easily control. I just skip up this. Now, clomiphene citrate, you know the negative side effects of this, so now it is almost out. Now, one should always use with caution. No doubt, letrozole was the first line of drug for breast cancer, and now it is permitted to be used for fertility. But still, we should not just give it like clomiphene citrate we used to give. Clomiphene citrate, any patient walking into your chamber like 3 years, 4 years back, it was 6 cycles with one doctor, 6 cycles with another doctor, like that. And what was happening, they were losing their good eggs with clomiphene citrate. See, we feel so, so easy to prescribe to anybody and everybody without checking the male partner, without checking their sexual history, without checking ovulation, without doing any follicular monitoring. But that was the trend. And when the patient lands up to you, she has no eggs because everything is recruited and she has lost the reserve. And no doubt letrozole is very conservative on that, but you have to use it judiciously. Now you all know the advantages of letrozole. It is very well accepted as the first line of treatment for ovulation induction. Now what are the newer drugs in PCOS? Very, very important. Melatonin, decioinositol, aminosytol, vitamin D. We never thought about it. Now 100% people on the road, I'm telling you, not 99, 100% people on the road in India, they are vitamin D deficient. And it is one hormone, one vitamin which is most important to us, and we have never talked about it. And it creates wonder if you give it to the patient. And what I have started doing is, the oral preparations, they really don't work. Somebody has indigestion, somebody has loose motion, somebody has forgotten about it, somebody is taking with the food, so no absorption, somebody with the milk. So to avoid all this, you give Rakitol 6 lakhs subcutaneous once in a week, 4 weeks. That's it. I take it myself. And I do my... नहीं हो रहा. I have done the study on myself. नहीं हो रहा. I am doing it myself. Because see, doing a vitamin D evaluation is more expensive than giving injection. No, but the response is there.
हम तो एक देते हैं और दूसरी उसको अगर बहुत ही कम हो तो तब दूसरा देते हैं, और वो जो हमारे एंडोक्राइनोलॉजिस्ट हैं ना, वो तो हाइपर हो जाते हैं.
I have gone through literature No, no, no. I have gone through it. I'll tell you my experience. You know, we were giving all vitamin D sachets, but it was not working. And because patient has come to you, they want immediate result. You know, you have to give them the success in the same cycle. So you have to build up vitamin D levels. And they start reflecting when you see the endometrial growth. Then chromium and...
चार्ट देने वाले कौन-कौन है सर और आप भी?
No, after I have done it on myself. And you will feel...
अमरीश मित्तल हमारा दोस्त है, वो कहता है कभी मत दिया करो।
मैडम क्या है?
मैम वो लोग ये कहते हैं कि it should not be given in 6 lakh units. आप धीरे धीरे उसको डेली डोजेस में दो. They don't even like to give weekly. वो कहते हैं वीकली में भी ये ऐसे पीक जा रहा है फिर ये ऐसे जा रहा है. आपको डेली स्लो वाला जो है they prefer that. बट वो सर की बात ठीक है, हमारे पास टाइम नहीं है, हमें जल्दी रिजल्ट लाना है तो
I have gone through the toxicity of vitamin D. Does not help. Even patient who is 24 hours like outside in the open, enjoying the sun, still he does not get any toxicity because of high vitamin D. So vitamin D is a very, very important part of maintenance for a female to get that. Aqua, this is aqua form only.
ओरल एक्वा भी आ गया सर.
Same, they are the same. If you are giving by oral route, it is
ओरल एक्वा.
powder or liquid voice. Does not make any difference. No, madam, it is 15 rupees an ampule, 6 lakhs. And the test for vitamin D is maybe 1800 rupees.
ओरल एक्वा प्रिपरेशन.
See, you can give it to the small 26 gauge needle. The patient can take it himself. Then vitamin D, B12, very, very important, especially in vegetarian. You know, it's not there at all. So you have to build it up. So these are the vitamins which were really neglected. Now, shall I go into details of melatonin? No. See, what is the role of melatonin in PCOS patients? We know that intrafollicular fluid is deficient of melatonin, so which is accounting for the poor egg quality and anovulation. So melatonin as well as its metabolites are potent direct free radical scavengers. They are like cleaning up the internal milieu. So in a recent study, the role of melatonin in protecting oocytes from ROS damage they have done, and consequently in improving oocyte quality and pregnancy rate. So to clean up our system, we need that. And they are like, you know, once you are smoking and you are, you know, taking alcohol, it is like that. So you have to clean that. Now similarly, role of inositol phosphate in oogenesis, then vitamin D as I discussed. Then what happens if you are able to correct vitamin D levels? It increases insulin resistance, you know, and obesity. So it settles down that, it increased androgen levels are settled down, poor follicular maturation improves, then menstrual irregularity improves. So in general you feel much, much better. You know, as a general well-being, it is very good. Yeah, you know, and it improves ovulation, follicular maturation, and you know, irregular periods are corrected. Then dose of gonadotrophins in IUI. See, how do we manage IUI? I feel the simplest and the best is letrozole. And if you find everything is going fine, dating is okay, follicular maturation is okay, that should be the preferred choice. But if you are not getting ovulation, see, in PCOD patients, the biggest problem is ovulation or more ovulation or no ovulation. See, if it is ovulation is there on letrozole, nothing to touch. Just let them do it. Let them have regular intercourse. and you have to exclude the tubal factor, ovulation factor, and you have to document the rupture in the previous cycle, and timed intercourse is important. And if male factor is also fine, then you don't need to bother. The chances of pregnancy are very good. But if there is no ovulation, that is the tough task what you have to manage. Now there are different protocols which are available. One is step-up protocol, which I have been doing, because you know that ovulation is under your control, what kind of recruitment you have got. So what I do is I give letrozole so that there are less number of follicles start coming up. Then I supplement with small dosages of HMG as required, and recombinant preparation most of the time, because they are high in the LH already. So instead, don't give them any urinary preparations. Now, step down protocol is also very popular. It is personal choice, but I try to avoid it. Then sequential stimulation is also being done by people, but still I feel step up is the best protocol. You are able to control your stimulation. Yeah, and it is best suited for patients with resistant to clomiphene citrate.
So, but it takes a long time and a huge dose for a step-up protocol.
See, ovulation has to happen. Then only you can think of pregnancy. Even if it goes to day 20, doesn't matter. You know, it is not like that. It should be like day 12, day 11, day 13. Let it go. Because the day you have not seen the patient, next day you see she is hyperstimulated. So you have to keep it checked. In fact, what we were doing is, we were giving half the ampoule to the patient. 75 milligram IU unit, Gonelef, give 37.5. Share it with 2 patients, you know, so that you don't waste. So you should be very, very, you know, cautious about what you are giving. Now, patients who are hyper-responding PCOS, then step down. See, IVF is indicated when other ovulation induction therapies have failed. If you are able to achieve ovulation easily, then IVF is not the treatment of choice for them. And in the presence of other associated factors like tubal damage or male factor or non-consummation factor, or you know, stress factor, so then IVF is treatment. Now 33 to 50% of patients referred for IVF have PCOS. Now they have some category of PCOS. We have to really divide that this patient comes into what category, mild, moderate, severe. You know, see, you have to separate the severe category separately.
I know phenotypes are.
Yeah, because in them the eggs will be very bad. The chances of pregnancy will be very low, chances of hyperstimulation will be very high, and pregnancy rates will be low, chances of abortion are high. So these are the patients where you have to really take a call. And by looking at the ovaries, I believe, and looking at the AMH and the follicle count, you can judge that these are the patients, and looking into the previous stimulation protocols. You have to really design your protocol for them. Normally what I do is, I call them every day and see the estrogen levels, and normally I try to cancel them. And you know, make them aware that even if you get pregnant, chances are 10%, chances of missed abortion is 50%. Chances of getting your own baby is 10%. So now you tell me what you want. And if you do an inclination, chances of your pregnancy is 70% per cycle. And I can take you in a guaranteed package to have a baby. So ultimately you are looking at your baby, and then you are breaking that lineage, that X-linked genetic lineage. You're cutting it cross. You are treating not yourself but your generations. So normally it is accepted because that is the fact. You know, but nobody does that in depth. So if you have advise the patient that this is what you are going to do today. They agree. Now GnRH agonist for treatment of PCOS, you all know, it is happening. Then GnRH agonist to trigger ovulation, you know that, then you are not landing up into hyperstimulation. Then response of PCOS to stimulation. Poor responders, hyper responders, we have to look into all this. Decreased fertilization rate, because in PCOS the eggs are good, but the zona is thick. The sperms are unable to penetrate into the zona. So there is a zona tightening. Then that is how there is decreased fertilization rate. So even if normal sperm parameters, PCO, we do elective ICSI. The reason is most of the time the sperms may not be able to enter. Then no doubt there is risk of OHSS and high order multiple increased pregnancy rate. Now in PCOS, if you have more than 5 embryos, patient is little hyperstimulated, ovaries are still enlarged on the day of ET, and you know that once this patient gets pregnant, she will go into hyperstimulation. So we freeze all. We have been doing it now. About 10 patients we have done. It is very good. And next time when you transfer, then she is in a normal cycle. Even you don't need to give them any estrogen preparations also. So you can do in a near natural cycle. In vitro maturation, just we talked about it. We were doing it. It is very, very complicated. So not recommended. Now laparoscopic ovarian drilling, you people all have been doing. It has a specific role. There are 2 schools of thoughts now that do it or not to do it. But I feel there are few steps one patient takes, to reach to a conclusion. Then who are the patients who benefit with laparoscopic drilling? Is clomiphene resistant, slim PCOS, anovulatory, raised LH level. Now in case of pregnancy, she is high risk for miscarriages, diabetes, PIH, preterm, IUGR, IUFD. Then conclusion. Diagnosis can be tricky. Management is age and need oriented. Lifestyle modification is the crux. Fertility can be difficult but not impossible. And prevention of long-term implications should always be kept in mind. Thank you.
So that was very brilliant talk on PCOS, giving us the practical tips. I would like to ask, are you